Hello, everyone, and welcome to Heads Up, the weekly webcast and podcast of the National Headache Foundation. I'm Dr. Lindsay Weitzel, founder of the Facebook group Migraine Nation, migraine strategist, and chronic daily migraine survivor. I am super excited to be here today with Mark Greco. Hi, Mark. How are you?
Hi there.
Mark is a physical therapist. He is also the manager of the Amita Diamond Headache Inpatient program. He is here today because our title is something that we haven't talked about yet, but it's really important to all of us. We're going to talk about the role of physical therapy in our headache disorders, how it can help us, what we can do. And this is a broad topic. So today we are going to zero in on specifically the role of physical therapy in migraine, cervicogenic headache, and in some of the vestibular disorders that are associated with our disorder, including vestibular migraine. So we will come back at a later date to speak to those of you with NDPH, post-concussive issues and stuff, and the role of physical therapy in these disorders. So we don't have time to talk about everything in one episode, so be patient with us. So, Mark, how are you today? Thanks for being here.
I'm doing great. Thanks for having me.
All right. Well, let's start. My understanding from hearing you speak before on this really interesting topic is that physical therapy for visits related to headache medicine is generally, it can be broken down into two areas, sort of like orthopedic and neurological. Can you sort of explain that for us?
Sure. So a lot of times neck can play a major role in how you're experiencing your headache.
Mm-hmm.
That's when your neck is a bigger player, that'd be orthopedic. And when you have an orthopedic component to your headache, generally you're going to see physical therapists a little bit more often during the week, let's say 2 to 3 times, but you might not see them for as long a duration, so maybe 6 to 8 weeks.
Okay.
Neurological, maybe more dizziness in nature, maybe more fatigue, nausea, lightheadedness, things that are more neurologically generated.
Mm-hmm.
That you may start off at 2 times a week and maybe progress down to 1 time a week, but would certainly have a longer duration. So less times during the week for a longer period of time, 12 to 14 weeks.
Okay.
Just because of the nature of neuroplasticity.
Okay. So let's talk about, let's start with some of the orthopedic and neck related issues that we experience and what PT can help with. I wanted to start with something that I find very interesting that I heard in one of your talks. What is prodrome neck pain, and what is it that you can tell us to do with it?
Yeah, a lot of the nerves in the neck and the trigeminal pathway, which is the pathway inside the brain that the migraine tends to originate on, they're connected. So as that migraine is starting to develop itself, or that headache, there's a prodrome neck pain starting inside of that nervous tissue. And as we know, a lot of hyperexcitability inside of that nervous tissue can create some symptoms in your neck, such as allodynia, which is a lot of sensitivity on your skin, and also a lot of tightness and guarding.
Mm-hmm. What is guarding? Can you define that for us?
Sure, I'd love to. So guarding is a natural protective response of our muscles where they get tighter to try and protect an area that is painful, is one way. So we can experience guarding like we just talked about in the prodrome, where that's more of an automatic neurological process inside of that prodrome of a migraine, that those muscles can start to guard that specific area. The difficulty with guarding is that over time it creates tightness and pain.
Okay, so I find this very interesting because I think we all experience it, we all notice it, but I don't think many people talk about it, or that our healthcare providers really discuss it with us. So I think this is going to be a really interesting episode to people. So what can a physical therapist do for us with these types of problems, guarding, etc.?
So a lot of it comes down into teaching you about your body, recognizing guarding and prodrome early, and so that we don't go down a path for several days or weeks, and teaching gentle stretches. A lot of times individuals are perform stretches to actually gain more range of motion, but stretching is actually much more useful, especially in this population, with just reducing tension. So going about only 60 to 70% of how far you can go. For example, an upper trap stretch, you wouldn't go all the way that you can go, but maybe just tilt and feel that gentle pull to get that sensation of pulling to help that muscle neurologically relax.
Okay, so I have a question. I do meet with a lot of people, see a lot of people who won't go to PT because they are so afraid that any movement like that is going to trigger migraine. They feel like they associate this type of movement with more pain. Can you speak to those people?
I would love to, and I think that going to the right provider is important. I think one-on-one care is really important in the headache population, and making sure that you're as the patient being your own empowerment and feeling free to communicate with your physical therapist inside of what you're experiencing. Having open conversation on the front end, letting them know that you do have a certain amount of anxiety or fear about these movements, and that there's a fear of creating an additional migraine.
Right.
And hopefully that open communication with your physical therapist will help starting slow, because starting slow in physical therapy with migraine is incredibly imperative to a successful outcome. Too fast and too hard, it does not work well, and I've heard that is unfortunately the experience that some people have had when they go to physical therapy. Okay.
So how effective is PT in decreasing pain in people with chronic migraines specifically?
So the evidence is we're working on getting more evidence, but because there's such a strong neck component, and when you have neck pain, you're more likely to have migraine, that there's strong evidence to support physical therapists and work with neck pain. So stretching, postural re-education, making sure that we're not just throwing our shoulders back, but looking at the entire pelvis, upper back, neck complex, and looking at how we're holding ourselves more continuously throughout the day. And also, it's really important that we start to look at not only how the therapist can help us, but what we can engage in a relationship about teaching each other about how we can work outside of the therapy session better as well.
It's funny, as soon as you said that, I could feel myself sitting up straighter. All the audience probably saw it too. So how about cervicogenic headache? Let's switch to that. Are there interventions that are different for cervicogenic headache than from what you just said?
Very much so. What we just discussed, the guarding and the more kind of more global neck pain is a little bit more vague. With cervicogenic, it's very specific. We do a specific test that includes moving your head forward and down and turning it. If there's significant limitations in what we call rotation, one way or the other during that test, and there's a pattern that is consistent with cervicogenic headache, it's actually fairly easy to diagnose. I have seen cervicogenic headaches, though, that have not been treated for a long time. They present typically with what's called a ram horn type headache. So it's going to come from the back of your head, up around, maybe even behind your eye a little bit. And it's usually unilateral, so it's on one side. And doing that test, turning one side or the other, you're looking at how your upper neck is working. And if you find limitations, you can do it's a really effective technique that the patient can do on their own, and the therapist can provide it as well. And then the evidence and the patient gets better really quickly. Okay,
that is good to know. So my next question was going to be, how effective is PT for people with cervicogenic headache? You sort of answered it. It sounds like you have good results in this case.
Yeah, we are probably the primary treaters in the specific cervicogenic case. While we kind of support
physical therapists.
So while some of the other stuff we can support some of the treatment that physicians can do in terms of finding a medication regimen that is useful. We're a little bit more supportive in that nature. With cervicogenic, we can really be a primary impact for these patients, and it's because it's more of a mechanical issue.
Okay. So let's move on to discuss more of the neurological category. How about those of us that experience dizziness, vertigo, and even the category of vestibular migraine? What sorts of interventions do you do for people with these issues?
So the type of interventions that we can do vary quite a bit. I think the first part is being able to figure out what type of dizziness you're having and when you feel that, and being able to treat each one as an individual. Dizziness and vertigo within vestibular migraine is generally a brain originated symptom. Right. So brains are individual, and so we have to treat them as individuals. Some of the things that we can do is we can do eye-head exercises to coordinate the eyes and the head a little bit better so that you're not feeling quite as dizzy. And the other things that we can do within vestibular migraine specifically is really work on what we call compensatory strategies, which is as you get that vestibular migraine, not that we're going to be able to really impact the migraine process, but what we can do is we can impact the experience and make it minimally challenging by using something called visual fixation.
Okay. So I guess I have a question. So many of us experience dizziness and vertigo with our migraines, even if we don't have an actual diagnosis of vestibular migraine. So how do we know when we should see a physical therapist? How do we know when someone like you can actually help us?
So my experience with these patients is it doesn't happen overnight. It usually progresses over time. And so when you're noticing a consistent activity that is impacting your dizziness and that is impacting your function throughout the day, for example, if you're emptying your dishwasher and you're noticing that down and up activity is creating dizziness and it's not very enjoyable for you and would add quality to your life to maybe manage some of that dizziness, I would go see a PT. We can be really helpful in making that activity a more enjoyable and less symptomatic.
Okay. That is a good answer. That is good to know. So is there anything else you would like to add today on our topic of physical therapy and headache disorders?
I just think physical therapy can be a big partner in treating migraines and headache disorders. It's a very complex issue, and usually needs more than one type of intervention. And physical therapists have the opportunity to spend a lot of time with the patients, and we have time to spend maybe 45 minutes, maybe 30 minutes, 2 to 3 times a week. A lot of times we can ask questions that can actually get down into what's impacting the migraine or the headache or the dizziness at a level that we can be helpful in communicating with the physician to create a more comprehensive treatment program.
Okay. I can say that in my 30 years of chronic daily migraine, I don't really remember anyone telling me to go see a physical therapist. And now it's over 10 years later. And I am, significantly better, but I just don't feel like I was told to see a physical therapist. So I find this topic hugely interesting. I loved hearing your talk, and I do wish that I had been told to go see a physical therapist, and I'm curious how much it would have helped me when I was at my worst. So I hope that everyone found this interesting, and thank you, Mark, for being with us today. And we will be coming to you guys again to address some of the headache disorders we were unable to address today. So if your particular disorder was not spoken to today, don't feel left out. If you have a post-concussive disorder or NDPH or something, we will be getting to you. Do not worry. So thank you so much, everyone, for joining us today, and be sure to join us next week on Heads Up. And
thank you.
Bye-bye, everyone.
Have a good one, everybody.